All right, picture this. You're on a super busy med-surg floor. I mean, your patient list is a mile long. Call bells are going off like crazy. And then you hear a phrase that just makes everything else stop. It's that phrase that kicks off one of the most critical journeys in all of nursing, cardiovascular care.
This right here. It sounds so simple, doesn't it? I get short of breath when I make my bed. But you and I know, as nurses, this is way more than just a comment. It's a huge clue. It's telling us that a simple, everyday activity is totally overwhelming the heart. And this is right where our clinical brain has to switch on.
So that one sentence, it triggers the first and honestly the most important phase, our initial assessment. We have to figure out fast, what is going on and just how serious this is.
Your nursing brain just kicks right into high gear, right? You're scanning for those big, scary signs. Is there any angina? That classic chest pain. We've already got the shortness of breath. Are they diaphoretic, that cold, clammy sweat? What about nausea? These are the bright red flags that are just screaming, "Hey, we've got a heart problem here."
Now, when it comes to chest pain, we have to dig a little deeper, and this is absolutely critical. Is it stable angina? The kind that's predictable? It happens with exertion, and it gets better with rest. Or is it unstable? The kind that happens even when they're just sitting there and it's getting worse. Getting this right changes everything, because unstable angina is a huge warning that a heart attack could be right around the corner.
Okay, so once we've got the patient stabilized and we've gathered those first initial clues, it's time to decode the data. We need some hard, objective proof of what we think is happening inside that heart.
And our first tool for that is the ECG. And listen, analyzing an ECG isn't just guesswork. It is a systematic, six-step process. You calculate the rate, you check the rhythm, you hunt for those P waves, you measure the intervals, you look at the complexes. Following these exact steps every single time, make sure that you don't miss a thing. It's like a safety checklist for the heart's electricity.
And here's why that system is so important. Look at this. On the left, you see a beautiful, perfect, normal sinus rhythm. Every measurement is right where it should be. But on the right, totally different story. That's supraventricular tachycardia, or SVT. The heart rate is just shot up to 145, and you can barely even find the P waves. Following those 6 steps is what lets us confidently say, yep, that's SVT, and get the right treatment going.
Okay, next up, labs. When heart muscle gets damaged, it releases these very specific proteins into the blood. You can think of it like a chemical fire alarm. And the ones we really care about, the ones that are most specific for a heart attack, are the troponins, T and I. They start creeping up within just 2 to 3 hours and can stay high for up to 2 weeks.
Seeing the actual lab values here really drives it home, doesn't it? As a nurse, you're always comparing your patient's numbers to these standards. And when you see that troponin level pop up, that's it. That's your confirmation of a myocardial injury. It's really the final, definitive piece of the diagnostic puzzle.
So the assessment's done, the data's in, and it confirms our worst fears: a heart attack, a myocardial infarction. And now we are entering the most critical phase where literally every single second counts. We are racing the clock because time is muscle.
This shows you exactly what's happening inside our patient's chest. We're looking at what's called a STEMI, an ST elevation myocardial infarction. See that? A blood clot has completely blocked off a coronary artery, and all the heart tissue that artery was feeding is now being starved of oxygen, and it's starting to die.
90 minutes. This is the magic number. It's burned into the brain of every ER and cardiac nurse. The American Heart Association recommends a door-to-balloon time of 90 minutes or less. That means from the second that patient comes through the hospital doors to the moment we inflate a balloon in that blocked artery, the clock is ticking. And the goal is incredibly simple and unbelievably urgent: recirculation. We have to get that artery open again. And we do that with what's called a percutaneous coronary intervention, or PCI. A whole team rushes the patient to the cardiac cath lab, and a cardiologist threads a tiny catheter up to the heart to bust that clot and get the blood flowing again. So, the immediate crisis has been handled, but the journey, it is far from over. That heart attack has likely damaged the heart muscle, and that often leads to a whole new chronic diagnosis: heart failure. So our focus has to shift from a sprint to a marathon, where medications are going to be the key to long-term success. All right, let's talk meds. First up, a huge one: ACE inhibitors. You'll know them because they end in pril. These are an absolute cornerstone for heart failure. They work by opening up the blood vessels, which makes it way easier for a weakened heart to pump. But for us, we have to be on the lookout for that annoying dry cough, high potassium levels, and especially angioedema. That swelling of the face and tongue, that's a straight-up medical emergency.
Next are the beta blockers, the ones that end in "all." These are proven lifesavers. They work by slowing the heart rate and lowering blood pressure, which basically gives the tired heart a much-needed break. Our job? We have to monitor for bradycardia and hypotension, and hold that dose if the numbers get too low. And one of the most important things you can teach a patient, you never, ever stop taking these suddenly.
And then there's digoxin. I like to call this one the tricky helper. It's a really powerful drug that does two things. It gives the heart a stronger squeeze while also slowing the rate down. So yeah, it can be a lifesaver for some patients, but it comes with some pretty significant risks.
And here is exactly why it's so tricky. Just look at that number. That's the therapeutic range for digoxin. It is unbelievably narrow. I mean, the line between a dose that helps and a dose that's toxic is razor thin. It makes our nursing assessment so important.
And because that range is so ridiculously tight, every single nurse needs to have the signs of digoxin toxicity just memorized. The early signs are usually GI stuff, like nausea or losing their appetite. But the classic textbook signs are those weird visual disturbances, like seeing yellow-green halos around lights. And of course, a dangerously slow heart rate.
Okay, so our patient has made it through the storm. They're stabilized on their new meds. And now, the final, and I would argue the most important part of their journey begins, patient education. This is what's going to keep them safe at home and prevent them from coming right back to the hospital.
And our teaching has to be really specific. You know, if their main problem is coronary artery disease, we're going to focus on lifestyle things like exercise and blood pressure control. But for heart failure, the focus totally shifts to things like fluid and sodium restriction, and teaching them that critical skill of daily self-monitoring. We're basically empowering the patient with these simple daily tasks, getting on the scale every single morning, same time after using the bathroom before eating is the absolute best way to catch fluid retention early. A weight gain of more than, say, 2 or 3 pounds in one day is a red flag, and they need to call their doctor. This is how the patient becomes the most important person on their own healthcare team.
So we've walked through this whole journey together, from that first quiet complaint all the way to detailed planning for life after the hospital. It's just an amazing testament to the skill and the critical thinking that nursing requires. Which brings me to a final thought. With so much to teach and so little time before they go home, what do you prioritize? Of all these incredibly important lessons, which one are you going to teach first?